Again, good morning or good afternoon if you're on the East Coast like we are. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health. On behalf of Duke-Margolis, I'd like to welcome all of you to today's Health Policy Talks with Dora Hughes on achieving health equity through healthcare transformation. Health Policy Talks is a Duke-Margolis speaker series intended to highlight innovative, evidence-based, and policy actionable healthcare reform topics, including research, projects, programs across a range of healthcare areas of interest. Our goal is to provide a distinguished health policy leader an opportunity to bring their thought leadership to a broad audience and to help us make progress on transforming care and supporting some of the goals of better health outcomes, more effective innovation that really motivate a lot and greater equity that motivate so much of the work we do at Duke-Margolis. And I know so much of the work that many of you who are joining us today are deeply committed to as well. We're going to bring in a series of speakers each year from public sector, from private sector, from the commercial sector in these efforts. And I hope you'll join us in future sessions as well. Before we get started, I also want to thank some of our Duke-Margolis team for making the Health Policy Talk series possible. Will Blesser and Andrea Toomey as the lead organizers, and Lynn Glussman, Sarah Dunn-Phillips, and Kate Bundor for coordinating the educational components that go along with these talks, and Luke DeRocher, Morgan Romine, and Patty Green for the excellent work on events management and communications. So let me, without further ado, turn to introducing Dora Hughes. Dr. Hughes is the Chief Medical Officer at the CMS Innovation Center at the Centers for Medicare and Medicaid Services. She leads the center's work on health equity, and she provides clinical leadership and input on models, including serving as the Innovation Center's primary liaison with medical and clinical stakeholders, and providing a strong leadership role for CMMI's interactions with the clinical community. She's also part of the senior leadership team internally at CMMI and part of the efforts at CMS to make sure the activities undertaken in the Innovation Center are really linked to aligned goals and policy reforms throughout all of CMS and beyond. Dora brings a tremendous amount of experience to this job, previously serving as an associate research professor of health policy management to the Milken Institute of Public Health at the George Washington University, where she focused on many of these issues related to community health and health equity, social determinants, and how can we make healthcare policies work better to support progress on those key issues. Before that, she was a senior policy advisor at Sidley Austin, working on regulatory and legislative matters in life sciences and touching on many of these same issues. She also has a long and distinguished history of public service, serving previously as counselor for science and public health to then Secretary Kathleen Sebelius at HHS, where she helped implement the Affordable Care Act and provided oversight on and guidance on the Public Health Service Act authorized agencies, including but not limited to FDA. She started her career as a senior program officer at the Commonwealth Fund, and where I first met her was when she was working with Senator Kennedy. She served as deputy director for the Health, Education, Labor, and Pensions Committee, showing some ways to make bipartisan progress and work on some very challenging issues from early in her career. She subsequently served as health policy advisor to former Senator Barack Obama, and before that has a distinguished background with an MD from Vanderbilt and an MPH from Harvard. She completed a residency in internal medicine. And Dora, we really want to thank you for joining us today and putting all of these facets together and making a difference in health reform.
Thank you. Thank you so much for having me. I will start with an apology. Of course, today the CMS Zoom is not working at 100%, but hopefully we'll make it through this presentation without my dropping off. Apologies in advance if I do so. I'll join as quickly as possible. The title of my presentation today is Advancing Equity Through the CMS Innovation Center. And if you go to the next slide, I thought I would start with a story, a true story, that was relayed to the CMS Innovation Center from one of our model demonstration participants. It was about a young single mother of 3 in Pennsylvania Despite everyone in the family being insured and having a primary care physician, she and her children routinely visited the emergency department for non-emergent reasons, which came at a cost of tens of thousands of dollars. When she brought her youngest son, a 5-year-old, into the emergency department for the 17th time, she was screened for health-related social needs as part of the CMS Innovation Center Accountable Health Communities model. It was discovered through the screening that the mother was being threatened with having her utilities cut off. There were water leaks and mold in her apartment, lead paint and lead pipes, and she and her children were forced to rely on portable heaters and a stove for warmth. Staff from this Accountable Health Community site, called the Reading Hospital's Community Connections Project, connected this mom with legal services who helped her fight back against her landlord's unreasonable demands. They helped her get her heat turned back on and assisted her with a new housing application and addressed other issues. Today, the family reports having most of their social needs resolved, and they now happily reside in a new apartment. The mother shared her son's favorite everyday proclamation, "We're home, Mom," and their health issues, not surprisingly, have significantly improved as well. If you move to the next slide. The Accountable Health Communities is one of 28 different communities across the nation that really work to bridge community and clinical health interventions to improve health, improve quality of care outcomes, and reduce costs. Here, as you see, they bridge hospitals, the primary care sites, the pharmacies, behavioral health, all of those on the clinical delivery side are bridged with transportation, housing, utilities, food service providers. They also address intimate partner violence in a way that, again, if we can address the holistic needs of patients, as part of the test, the question was, can we improve health outcomes and reduce costs? And even though we don't have the full final evaluation findings, an early interim finding did find that in addition to being able to successfully screen patients and connect them to services, they did drive down utilization of the emergency department by 9%. Also of note for this model that 2/3 of the beneficiaries served were Medicaid beneficiaries. And we found that at least a third did in fact report a social need. If you move to the next slide, for those of you that are less familiar with the CMS Innovation Center, this model, the Accountable Health Communities model, is one of many models that through which we are seeking to fulfill our statutory charge, that being testing innovative payment and service delivery models that can improve quality and reduce costs, at least one or the other, ideally both, but that is our charge. And we have a number of alternative payment models that can focus on a specific health condition, such as diabetes or end-stage renal disease, cancer. They can focus on a specific care episode through our bundle payments model, for just joint replacement, for example. Our models focus on specific provider types, such as primary care, or even ambulance, paramedic providers. We focus in certain communities, such as rural areas, and we focus across the different insurance lines, whether that's traditional Medicare, Medicare Advantage, Medicaid, Medicare Part D. We look broad in our mission to test, again, these models to improve quality and reduce costs. If you move to the next slide. This site, since our inception in 2010, we have sponsored over 50 different models and demonstrations. I'm not going to go through all of them here, but you see that they do span across the 5 different areas that I just outlined, whether it's accountable care, our accountable care models, our episode payments, primary care, and so forth. If you move to the next slide, I think it's important to note that we have had a broad impact. In one 2-year study, from our analysis, we touched over 28 million beneficiaries across all 50 states, and over 500,000 providers and provider groups have participated in our model. Again, that was in one 2-year period. We think that we have an even broader range of impact. If you go to the next slide, As part of, in 2020, as we thought we hit our 10-year anniversary, it was also around the time the administration changed, it made sense to take a look back and think about what have we learned in the past 10 years? What are some of our accomplishments? But also, what are some of the challenges and opportunities that should inform the next 10 years? And with respect specifically to equity, we had a number of findings. The first, in our models, we did not always focus on health equity. We didn't focus on health disparity, include Medicaid or other safety net providers. Another, when thinking about safety net providers, too many providers were unable to accept downside risk without assistance or inducement. Next to last bullet, the success of models are too narrowly defined. Sometimes we look so narrowly at cost and quality. We miss some of the other transformative aspects of our models, and I'll touch on that in a bit throughout this presentation. And in the final bullet, although we have been so fortunate to have an amazing cadre of colleagues who have really joined us on this journey to value-based care, we realized that some groups we had not fully engaged, certainly beneficiary groups, certainly patient advocacy groups, certainly groups that are representing underserved populations, safety net populations. So we wanted to broaden, we needed to broaden the range of groups and professional societies, patient advocacy groups, who we are engaging, and most particularly beneficiary groups that we thought should be certainly our top priority. So if you move to the next slide, and thinking about the lessons from the past 10 years, of course, the question is, well, where do you want to go for the next 10 years? What are your 2030 goals? And we established the vision statement that you see here, a health system that achieves equitable outcomes through high quality, affordable, and person-centered care. And within that vision statement, to achieve this vision, we have 5 key objectives. The first one is that we want 100% of Medicare beneficiaries and the vast majority of Medicaid beneficiaries to be in relationships defined by accountability for quality of care and total cost of care. The second objective focuses on health equity. I'm going to dive a little deeper in that on the next slide. The third bullet is support innovation. What are the technologies, the tools, the data that's needed to help support transformation in the healthcare system, particularly for our model participants? The fourth objective focuses on addressing affordability. How do we drive down cost of care at a systems and individual level? And the fifth area, again, is partnerships. How can we better partner so that we have meaningful participation across all of our different model types? So if you move to the next slide, advancing health equity, we are focused in 4 key areas. The first is when we think about new models, and certainly existing models that have at least 3 years left in the model lifespan, how can we better embed health equity and social determinants of health? What are the opportunities to do more here? The second bullet, how do we increase the number of beneficiaries from underserved communities? And the key to that strategy, how can we increase the number of safety net providers that are participating in our model? That includes those taking a large number of Medicaid patients, those include those working at federally qualified health centers, other safety net providers that we think, again, are key to engaging more underserved beneficiaries in our models. The third always sounds very straightforward and a little bit of ho-hum, but we found in our first 10 years, since we weren't always focused on health equity, we did not evaluate our models specifically to learn the health equity impact and what data and lessons learned that could inform future work. So very straightforward, but just very important. And the final, which I think in some cases is the linchpin, the foundation to all of our efforts, is that we really need to strengthen socio-demographic data collection and intersectional analyses that could both help us better monitor our models as well as evaluate our models as it's going through the implementation period, and to help inform thinking for future iterations of these models and next steps. So then if we move to the next slide, I wanted to note that we are taking the life cycle approach to embedding equity in the very front end when we even think about the models. Does it have relevance for health equity? What are the components? What are the provisions that can address the health equity concerns of the target populations? Recruitment and rulemaking, again, how are we recruiting safety net providers? What types of technical assistance or financial supports might they need, particularly including through the application period? Our efforts won't stop with implementation. Again, we have learning communities, supports, webinars. What can better help our participants? And the final area, scalability. For many of our models, there have been successful outcomes, lessons learned. How can we make sure that we are disseminating these lessons learned so that they can be adopted and adapted by providers moving forward? So across the lifecycle approach, we think that that provides many opportunities to embed equity. If we move to the next slide, I did want to note that some of our work right now is really highlighting the importance of taking this very deliberate, systematic approach. When we look, for example, at the primary care sites that were participating in our models in the Los Angeles area, if you look at the clear open dots, those are the primary care sites. But if you look at the maroon, darkly colored maroon dots, those represent communities with high numbers of Latinx residents. And so you can see here, there's a mismatch between our primary care sites participating in our models, and in this case, the Latinx underserved communities in the Los Angeles area. And so you might think, well, is this an outlier, or did this happen in the Los Angeles area? If you move to the next slide, you'll see that we found a similar situation in Detroit. In this case, the open dots represent primary care sites participating in our models. The pink dots represent African-American communities. Again, a mismatch between our primary care investments and underserved communities that we would really like to include in our models, and in some cases may actually derive disproportionate benefit from our transformational work, given the disparities they face. And so again, just really asking the questions, being very thoughtful at the outset, what are the models focused on? How are we designing the models to maximize participation across all of our beneficiaries groups? How can we follow and monitor it over time to making sure we're reaching our goals? And on the back end, evaluating for the health equity impact are all just very critical steps. If you move to the next slide, I did want to share a few model initiative highlights that will highlight some of the work that we're doing in health equity. If you move to the next slide, I started mentioning our accountable health communities model, which in some cases I would consider our vanguard model in terms of addressing equity, screening for social determinants of health, social needs, helping our beneficiaries navigate, connecting them to the social services organizations that can help. Even though that model has wound down, we are already building upon what we've learned from that model as part of other newer models, the integrated care for kids being one such model. This model is focusing on the pediatric population, working to identify children with mental health and other health needs, and thinking through how can we better connect them to both the clinical care that they need, as well as, again, the community health interventions that can address some of their social needs. And I always found when this model was first announced as a provider, I was shocked that CMS, the nation's premier healthcare institution, would have as one of its health outcomes out-of-home placement, foster home placement for the children in this model. And I think that it's really a strong signal of how we are trying to work very closely together with our social service and public health colleagues to bridge interventions in ways that we think will have a greater impact on their health and health outcomes in the long term. If you move to the next slide, another example is our maternal opioid misuse model, or the MOM model. Both the Inc. model and the MOM model are relatively new. In this case, we're focusing on, obviously from the title, pregnant women and their infants, newborns, really targeting a very high needs population, those that are experiencing opioid misuse, how do we connect them to both the clinical care that they need, as well as screening and addressing social needs that can help them stay in treatment for both their addiction, but also for the maternity care. And if we take this holistic view for this very high needs population, what will the impact be, again, on their quality of care, their health outcomes, and costs? We certainly, particularly given this administration's prioritized focus on maternity care, we're certainly very excited to see what we'll learn from this model. If you move to the next slide. Primary care, we have made a significant investment in primary care, starting with comprehensive primary care model, our comprehensive primary care plus model, and our primary care first model. As you see, there's nearly 3,000 practices in 26 different regions. We're seeking to better coordinate and integrate care using care management, the latest data technology tools that is enabled in part by the flexible payment that we're providing. In this primary care model, these practices are those that are very advanced, very familiar with accountable care, sophisticated practices. We have signaled that we're interested in bringing more primary care practices, those that might be newer to accountable care, bringing them into the fold as well. So we're certainly very much going to continue to invest in primary care. We see that is certainly foundational for healthcare for all of our beneficiaries that we serve. If you move to the next slide, I had mentioned as part of my opening and part of the opening slides that we do also include not just traditional Medicare, but we also have some focus on MA or Medicare Advantage. Our value-based insurance design model is certainly example of this investment. And particularly when we look at cross-VBA generally, but also through the hospice component, we are very much focusing on the needs of underserved enrollees through this model. In this plan, we have a number of plans are able to target additional supplemental benefits. You may be aware that Congress provided these additional authorities. And so our plan participants are thinking about how can we help our underserved populations, whether that's through reduced co-payments, if it's certain rewards and incentives that can be used, for example, to provide assistance with transportation or to address food insecurity. We are encouraged by the growth in the scale and the focus in special populations, as you see in this slide, from 2017 to 2022. Just the number, even if you just look at the target enrollees, increasing from 99,000 to 3.7 million target enrollees, I think, again, signals the interest and the commitment by a number of our model participants and the CMS Innovation Center in doing more in this space. So if you move to the next slide, we announced our newest ACO model in March of this year, ACO REACH, Realizing Equity, Access, and Community Health. We are certainly building upon our earlier efforts in the ACOs, as well as feedback and input from a number of our stakeholder partners that really encourage us to focus even more on health equity through the ACO REACH model. We have a health equity benchmark adjustment that we are going to test. We have requirements for health equity plans. We want our participants to know their population, know who they're serving, know if there's any disparities that need to be addressed, and to develop and implement interventions to address any disparities found. So we certainly are very excited about the health equity plan requirements. And we are also requiring demographic data collection for our participants in this model. We certainly are strongly encouraging also data collection on social needs and SDOH. And so I think, again, through the ACO REACH model, it really sends a strong signal of where we are right now and where we intend to move forward in terms of the requirements for our model participants. If you move to the next slide, and apologies, I know I'm marching through these pretty quickly, but I do want to leave time for some discussion. Also, in July of this year, we had piloted an implicit bias initiative internally. We wanted to look and see for ourselves if through our models, if we were inadvertently embedding any implicit bias that could affect our eligibility for the models or some of the decision making. We did find through 3 models, one focused on the Million Hearts Initiative, our CJR, our Comprehensive Care for Joint Replacement model, as well as one of our kidneys models, that we were embedding implicit bias in 2 of the cases based on our screening tools for eligibility. One that folks used the EGFR, which is a race-adjusted clinical tool to determine kidney function. That's one example that has gotten quite a bit of attention and is no longer recommended for use. But for us, it's, again, at the CMS Innovation Center, we want to be very thoughtful to see if any of our decisions, any of the tools that we might be relying on, if that's introducing bias into our models, and we're continuing to do more work there. If you move to the next slide. So what is to come over the next 10 years? We've talked about health equity. I do like to make the point that even though it's one objective, a very important objective, and we are laser focused on that objective, we are also thinking about equity across all of the different core objectives, the goals or pillars as part of this vision. I mean, we're thinking about partnership, for example. We are specifically thinking about how do we get patient voices from the full range of communities, as an example. As we're thinking about affordability, we know that there may be different implications depending on the communities that we're serving. Supporting innovation, what are the tools that we're providing specifically to help our participants adjust equity? And it's certainly accountable care as we're increasing our relationship and partnership with our colleagues in Medicaid, for example. That's another example of how we are trying to think through equity across all of our key pillars, in addition to our specific advancing health equity pillar. If you move to the next slide, just a few thoughts about what else is to come. We have focused certainly in many cases on racial and ethnic groups, in part because that's where we have the best data, even though there are certainly data limitations that we're working to address. But when we think about other populations, if we even look at CMS's definition of health equity, which is very much aligned with the administration's focus, there's a number of different groups that are mentioned. Groups that are defined by disability or sexual orientation, gender identity, geography, preferred language, really trying to think through what are some of the steps, what are some of the provisions, what are the interventions that could address the needs of the full range of underserved populations that we need to think about that have and continue to face health inequities. If you move to the next slide, I mentioned previously, we are also very much focused on how do we scale up our successful models, how do we sustain them in the long term. I think 2 examples here are Medicare diabetes prevention program, very strong model, evidence focused. We were certainly are able to certify it for expansion. How do we make sure that all of the populations that are at risk for diabetes are able to benefit from this program? And this is just one of many examples. Similarly, when we think about a strong start for mothers and newborns, we tested birthing centers, we tested the midwifery model, we tested maternal homes. We had very strong findings and across Latinx and African American populations, moms that are increased risk for, in many cases, for poor outcomes. How do we better disseminate these lessons? How do we make sure that they are adopted and implemented nationally so that, again, all of our beneficiary populations will derive benefit? If we move to the next slide. Drug pricing, I'm sure many of you saw the executive order that came out on Saturday that instructed the Innovation Center to think about what are some of the other prescription drug cost models that we might test that would complement the efforts being supported by our colleagues in the Center for Medicare. This too we're thinking through next steps. How do we embed equity? what are some of the drug pricing models or the prescription drug models that we might support that could center equity in terms of the populations, the drugs that might be selected, the cost sharing, all of that's on the table. But as we kind of narrow our focus and think about what potential models that we might want to tackle, certainly equity, thinking very deliberately about what especially could benefit from underserved populations will be a priority for us moving forward. Next slide. And I have to take a moment to just give a shout out to my colleagues who have been leading the Part D senior savings model. Since we mentioned the IRA, the Inflation Reduction Act, we do have to note as an example of one of our successes is that our Part D senior savings model, which provided insulin products capped at $35 per month, was picked up and included as part of the IRA package, is now so that in addition to beneficiaries participating in models, all of the beneficiaries at Medicare would be able to benefit from this capped, predictable $35 a month cost for insulin. So I think that's just a really great example of how some of the work that we are pilot testing here can become law and have just a really wonderful impact on healthcare and generally for across all of our different beneficiaries. So had to take a moment to give a shout out to my colleagues who have been at the helm of this model. Next slide. And then finally, I would just have to say in terms of partnerships, we are so forever grateful for the efforts of the Health Equity Advisory Team, or the HEAT, that was launched a little over a year ago as part of our Healthcare Payment Learning and Action Network. It's co-chaired by Karen Gell and Marshall Chen. They continue to put out helpful guidance and recommendations on how we can advance, all of us can advance equity through our models. The LAND Summit is November 9th and 10th. It will be virtual again. And I just highly recommend all who are listening today to join the summit and learn more about what this group has been deliberating on. They touch on some of the more tricky, thorny issues, such as social risk adjustment and other elements that can be considered as part of models that, again, would help to drive equity. If we move to the next slide. When Chiquita Brooks-LaShore, our administrator, was confirmed in May 2021, she noted that our agenda is ambitious, but the times call for bold action. She reminds us of this and holds all of us to this standard that we need to move quickly, we need to move intentionally. We also have to be bold. If we're going to achieve our goals with health equity, we are forever grateful to have so many amazing partners, including the Duke-Margolis Center, who are really helping to inform and advance our work, advance our thinking, and we are looking forward to continued partnership in the days ahead. So next slide, I believe that's my final. Thank you. We encourage you to look on our website to find additional materials related to today's discussion and certainly health equity in the weeks ahead.
Dora, thanks so much for that comprehensive presentation. A lot there, and just want to remind people we are going to make this recording available on our website for people who want to follow up. And I'll put in a plug as well for that Healthcare Payment Learning and Action Network Summit on November 9th and 10th. It's online. You can just Google it to find it if you're not already on the CMS mailing list, and I'd encourage you to get on it. That's a good way to find out more about some of these many initiatives that Dora described. Great way to do it. We'll answer some of them as we go along in writing, and we're going to get to as many as possible right now. I did want to pick up, Dora, maybe to start with your theme about what you've learned over the past decade and these big strategic pillars forward that are coming together with, if I could maybe rephrase or restate what you said, these comprehensive models of care like ACO REACH or integrated care for kids that are intended to put everybody at the center of a system built around them. Going back to that story started with in Pennsylvania, where clearly wasn't happening for that woman and her kids and family. Now it is. Can you talk about what's next? And you spent a good deal of time on accountable communities for accountable health communities initiative too. But as you said, that is an example of one of these models that's kind of run its course. Is there going to be another one like that's kind of directly at the community level, or is the insight here that you can build in more of these steps to support addressing social drivers and taking a comprehensive look, maybe better by building it around accountable providers that are in these communities?
Yeah. No, thank you. That's such an important question. When accountable health communities launched, it was almost in some quarters considered very revolutionary to think that we would be trying to integrate clinical and community care. Whereas now at this point, as we've moved in 2022, it's almost understood that that you should be thinking about the needs of the patients that you're serving more holistically, that you should be asking and screening not only for their clinical issues, but also for their social needs and even SDOH at a community level. So I think in some ways it's nice to see it become much more accepted. People understand the importance more. And so because of that shift, we have almost embedded that approach and a number of other models. I think that's and you're seeing that for, I mentioned the Inc. model and the MOM model, but even if you're looking for our ACOs, we are encouraging, and in some cases we'll be requiring both the screening, the collection of information, how are you going to intervene? So I love that it's shifted from being something new and different to almost, frankly, it's increasingly becoming the standard of practice. And that's, I think, in some ways how we would love to sustain that effort moving forward.
Standard of practice. So great to hear. And by the way, I think your Zoom is holding up well. I understand mine may be a little bit spotty from time to time, but hopefully we'll be able to keep this discussion in your remarks just how important it is. We really are going to be intentional about addressing equity or about improving population health and other dimensions. You need to be able to measure it reliably. Could you talk a little bit? I know you've been very much involved in this with the further steps that CMS is taking to advance reliable collection of data on race, ethnicity, and language. That was a key element, as you said, of the ACO REACH program. But as I understand it, you kind of left it a little bit to the ACO REACH organizations to find how to measure that and so forth. Maybe because we're not quite fully there yet on standard approaches, which seem like are going to be really important for continued progress in this area. And there are also some further questions about data on additional dimensions of diverse populations. You mentioned sexual orientation, geography, et cetera. Can you comment about what the strategy is there? It seems so central, being able to get reliable data, but also an area where you need trust and engagement from beneficiaries and some interoperability too.
Sure. And that's such an important issue because, as I mentioned, I think data is just the linchpin to all of our efforts. We at CMS, we're quite fortunate to have so much data. But at the same time, we still find that we are limited by the data that we have. And as an example, you mentioned if we think about disability, we do get data from the Social Security Administration. We know which our beneficiaries are disabled. But it's more like a binary yes, no. We don't have enough information to know, for example, is it a physical disability? Is it vision or hearing? Is it intellectual? But that's the type of data that you need in order to develop the interventions that can be effective and be tailored appropriately to the beneficiaries that you're serving. So that's an example of even as in some cases we're awash in data. It's not always data that we need. And similar situation for population defined by sexual orientation, gender identity. I mean, trying to think through, even if CMS doesn't have granular enough data, agency partners may have that data and are we able to access that data, which is it's always a bit ironic. I think I wanted some data that another one of the centers here at CMS had, and we found that no, we can't even always share data internally at CMS, let alone with other agents, our agency partners, or with other departments. And so it's understanding like what are some potential other sources? Is that something that we can tap into? How reliable, how recent it is, you know, all of those types of issues crop up. And also, to be clear, every center, we have our own statutory authority that defines when and for what purpose we're able to collect data. So we have to be very respectful that we are collecting the data appropriately, that's aligned with our statutory charge. And there's something that we could use and analyze all of that. So it is, it's been quite an education here in government to understand. But I would say we are quite fortunate too, because we have to create more opportunities as just part of the broader environment in terms of data collection. Even though we can require the data collected by our model participants, we still need data for our control communities, our control participants. And so for us, we would really benefit in terms of our evaluating models if there's more data collected, not just through our model participants, but generally across across Medicare and Medicaid, generally, that we would then be able to use. And so as part of that, we are quite fortunate that the CMS Office of Minority Health has kicked off a broad CMS-wide data initiative, really tapping into all the various centers to learn about the data that they're collecting, the authorities that they use, where they see the gaps, how we can all work together to achieve this broader goal. So sorry, I've talked a little on too long, but data is such a critical issue.
Yeah, I know it's an issue that you, as you said, it's the linchpin and these efforts to align across different authority components, not broadly, and seeing finding some best practices for aging all these. Several of the questions about basically one version or another of extending these models. So one question was about, well, this is nice for what about people in commercial insurance or other types of coverage plans? Also, barriers to access to care that go beyond just the traditional cover. Financial being a key thing for the CMI work going forward.
Yeah. So you did cut out a bit there, but I think I may have caught the gist of the question. It's like we're focused on Medicare and Medicaid, but what about those facing inequities in commercial populations, if that might be the question? That's right. Again, it's just a really important question, and one that we certainly are increasingly grappling with internally. First, we are quite fortunate to be enthusiastic participants in the Healthcare Payment Learning and Action Network, and we see that as one way that we, through the public-private partnership, that we can really directly engage with our plan partners in the commercial space to understand what are the mutual priorities, what are some of the commonalities in terms of the direction that we're heading, how can we work better together. But I also think even outside of the land, very generally, the CMS Innovation Center is focusing quite a bit on multi-payer alignment. And by that, we're thinking through, what about how wonderful it would be if we could use the same quality measures for Medicare, Medicaid, in the commercial space, if we're all rowing in the same direction, or if we're thinking about payment policies or financial incentives, that if we are directionally aligned, then that would encourage more providers to participate, to join in these accountable care relationships. As a very specific example, if I'm a provider and only 10% of my patients are on Medicare and 90% are commercial or 90% Medicaid, I might not join an APM focused on Medicare only, but if I knew that this APM was going to require the same quality measures that my commercial payers were going to require, that my Medicaid payers, then it makes sense to invest in the learning supports, the technologies, the tools that would support collecting those quality measures. And so that's the type of thinking, same on the payment side, same on the care delivery side. How can we all make sure that, to the extent possible and when it's feasible, that we are adopting a universal set or a harmonized set of measures along with our colleagues in Medicaid, along with our colleagues in the marketplace, the private plans, and to the extent possible with the plans that are outside of the marketplace. Again, to the extent we're successful in our efforts in multi-payer alignment, then we think that we will have even more success in our overall accountable care relationships.
Yeah, thanks, Dora. And I'm going to ask about an extension in another direction, hopefully more easily able to be heard with going off video now. Howard Eisenson basically is asking about, well, these all seem like important issues to address, but really hard to do through certainly traditional healthcare, but maybe even this expanded lens. What about the interaction with those housing supports or income supports or early childhood education that's clearly so important in Inc. I don't think, Dora, these new programs can do, these new initiatives can do everything, but can you talk about how you're thinking of they're fitting into other social policies and other reforms that could, that are also very important for advancing equity?
Right. No, I appreciate that. I appreciate that question. And that is the issue that we've also acknowledged, that in some cases, we at CMS, and certainly many of the providers in our programs, they don't have the expertise, they don't have the experience. Frankly, they may not have the bandwidth to take on all these various issues. And that is why, in part, we're so focused on partnership. Internally, as one example, we are working more closely with our colleagues in the Health Resources and Services Administration, or HRSA. They oversee the Community Health Center Network. They have been working in underserved communities since inception. They have a much bigger footprint on the ground. We can tap into their network, tap into their expertise as we move forward. Similar for the Centers for Disease Control and Prevention. They have been working in equity generally, but certainly in addressing social needs, SCOH, for years. And again, through the partnership, they also have a much bigger footprint on the ground, local, that can only help amplify our efforts. We are certainly working more closely with our colleagues in the Administration for Community Living, or ACL. Similarly, through their area agencies on aging and their other programs, they have a more direct link to many of the beneficiaries that we're hoping to serve. And that's just within the Department of Health and Human Services. We've also, across the CMS Innovation Center, a number of us have had conversations with our colleagues in the Department of HUD, for example, as we're thinking through what can we do on housing, and also what data do they have that we may be able to tap into and understand the needs of our beneficiaries, both in terms of housing security, but also potentially demographic data. So we're both working across HHS, but even outside of HHS, to really, we'll take all hands on deck if we're going to be successful. And we freely acknowledge our limitations, and are so grateful to have the assistance from our colleagues across the federal government.
Yeah, and just to your point about data and measures, with the similar goals that these programs have, these initiatives like Integrated Care for Kids has been a strong motivator for setting up that kind of data coordination to get the right services and supports connected to individual families. There's several questions. We only have about 5 minutes left. We could go on for quite a while, I know, but several questions related to kind of evaluation and what's next. Many of these models involve, as you said, moving farther away from fee-for-service, and many organizations that are starting out can't get there. You've, I know, tried to create a range of models, starting with upfront support for smaller safety net organizations that are just getting going, all the way up to advanced models like ACO REACH that are really aiming to sort of leave fee-for-service payments behind. How are you going to know, or can you say a little bit more about how you're going to know whether these new initiatives that are really seeking to be aligned around these broad themes are working? I know one of the findings from CMMI after its first decade was, well, we need to get away from just looking at individual programs in the short term and looking at how we're making progress on these broader goals of meeting population health needs and addressing equity, lowering cost growth, et cetera. So how are you going to know that this is all of this is working well together?
Yeah, that's it. I mean, if this, we acknowledge our agenda is pretty ambitious, and some of what we're testing is in fact a test. And I think if we look at our health equity plans, I mean, that is, I know externally health equity impact assessments or disparity impact assessments, those are not new ideas externally, but for CMS, this is not something that we have tested before, and certainly not at scale. And so and that's true for other areas where, whether certain care delivery requirements or certain benchmarks, adjustments. I mean, we at CMS Innovation Center, these are truly tests. And I think in the earliest phases, in some cases, it's really operational. Can we even do this? What is our statutory authority? What are the budgetary implications? What's the burden on providers? What, even if we think about data as example, what are the APIs that are needed? What happens when we collect the data? Where do we store it? I mean, it's all these operational issues that are really can really be complicated and thorny. And so in these earlier days, these are tests. We may not succeed. We may get some of this wrong. But we will have learned lessons that we can continue to build upon. And already, even as we're trying through ACO REACH and other models to take these first steps, already my colleagues in our evaluation group, research and evaluation group, we call them REG, they have already pointed out that even as we were taking these first steps, to start to think about where do we hope to be, how are we going to iterate, how are we going to get there? So even as we're focused at the here and now, that we're already starting to think through where we want to be in the next 3 to 5 years. And I think that also, we are also on a parallel track that's very much related, I think, trying to do a much better job of sharing data from our models with our external partners, so they too can augment the work that we do internally. Our evaluation efforts internally can be augmented by similar evaluation analyses externally. And so that hopefully that collectively we'll be able to figure out, again, what has worked, how has it worked, does it make sense to replicate it, how do we build upon it, so that in the next 10 years of our 2030 goals, that we will have a solid understanding of how we can advance equity across all of our other, across all our models, but also across some of the other priority areas as well.
Well, thank you for that comprehensive answer. Again, we could go on for a while. There are a few more questions asking what's next for the drug pricing models. The executive order was just announced this past week, so maybe a little bit more time for that to come. What's next beyond that? I'm sure, Dora, though, knowing how you and your colleagues are working, as you said, there is a 3-year, 5-year plan, adjusting all along the way, but staying true to these core themes. Just as a closeout, you quoted Administrator Chiquita Brix-LaSure saying that essentially our times call for bold actions. CMMI does get criticism. This is a time when healthcare providers are really feeling stretched on all sides. So asking them to do things differently in developing and implementing these care models. It's led to some criticisms, frankly. Some that say, this is too much much of a push or a leap, slow down. Some that say, well, this is too much of bringing in, the private sector and private organizations into Medicare. Any final words about how you get through the day and respond to some of the people who say maybe it's too hard to take these bold actions now?
We do get those criticisms. We do hear those concerns, but at the same time, we are also hearing quite a bit from others who are saying, you're not doing enough, you're not moving fast enough, you're not where you should be 10 years later. And so I really find it's equally helpful to focus not on what's hard to do, but also on what's important to do, and working with those that are helping push us along or pulling us in different directions that I think is, in some cases, is more valuable for us in the CMS Innovation Center. That the kind of push and pull, I think that on balance, we are clearly moving in the right direction. So I'm excited about what's to come. And I would also have to say, just maybe as a teaser in our final minute, we are at the 1 year since we released our strategy in October of 2021. We certainly will be sharing some of our thoughts about what we have accomplished in the last year. We also have some pretty interesting work and thinking in terms of specialty care. We will be sharing more of our thoughts about how we might approach the executive order. So I certainly strongly encourage all of you who have an interest to just stay tuned. And again, as always, we're forever grateful to have all of the assistance and guidance for so many of you who are watching today, who've just been tremendous partners all along the way. So, perhaps perhaps a too optimistic perspective, but nonetheless, I think one that's shared by most of my colleagues in the CMS Innovation Center, and I hope by many of you.
Dora, Hughes, you're not slowing down, and thanks for so much effort on these critical issues. I want to thank you. I want to thank everybody who joined us today for Health Policy Talks. Please stay in touch with Duke-Margolis about future events and future activities related to the kinds of themes we talked about today. And that includes our next Health Policy Talk coming up on November 17th with Frederick Asasi of Families USA, talking about the evolution of the healthcare movement with the value imperative. Thank you all so much for joining us today.